I'm going to introduce our next presenter, Steve O'Neill, another Steve. Steve O'Neill is the OpenNotes specialist in behavioral and mental health and is faculty in the Center of Bioethics at Harvard Medical School. Steve was the social work manager for most of the behavioral health practices at Beth Israel Deaconess Medical Center for many years, and where he's also the associate director of ethics support service. Through his leadership, he started the first ever program in making behavioral health therapist notes readily available to patients through their personal computers in 2014. And he's going to share with us right now everything he has learned since then. Steve O'Neill.
Great. Thank you, Liz, and thank you, Steve, for your presentation. It's and some of what I will go through, I'm going to try to skip over my own redundant parts, you know, that so we're not duplicating and we have enough time for questions and what have you. So I will talk a little bit about the experience of opening up notes in this. And what I'd like to do is kind of think about, for all of you clinicians, is to think about OpenNotes a little bit as another variation on narrative therapy. It's kind of a way to kind of capture behavioral health and mental illness, and really to kind of form more of a partnership with patients. And I will say, as a recurring theme, if you think about just the culture right now in our current culture with the pandemic going on and all that's been transpiring in the past week in DC, trust is a huge, huge issue for our entire culture, no matter where we're talking about. And if we can do anything to increase the trust that patients feel for us providers, I think that's a good thing. So that's a little of what OpenNotes is about, is to increase that culture of transparency and respect. So we start always with that question of what is best for the patient. And at Beth Israel Deaconess Medical Center, where I have been practicing many, many years, as part of a backdrop to that, I should mention that the very first electronic medical record in the world was started at Beth Israel back in 1986. Medical notes went online at our hospital. And all of our mental health notes went online in 1991. So we felt a little while later it was secure enough that we could begin to share notes. And for some of us, I and another colleague, we started a policy back better than 35 years ago. We would say to any of our patients who are coming in, if you want to see what we've written at any time, we're glad to show that to you. And that to me was kind of, it's not the same as the OpenNotes right now, but it was with patients being able to pull up the note to the computer, and if they wanted to see what they wrote, it was so helpful in getting them to settle down. And as the Associate Director of Ethics, when we started our ethics programs back better than 20 years ago, back in the 1990s, we started a policy that all of our ethics consult notes would be directly shared with the source patient involved and any involved family members that were involved in the consult. And these were oftentimes highly litigious situations or potentially litigious situations. Where in our hospital, our ethics support service averages for formal consults between 7 to 12 formal consultations per month, and a lot more informal, but the formal ones. And we would share the note in what oftentimes in the best practice, I would actually bring a draft of my note to the patient or their family so they could see whether I've captured their perspective, and then make sure I captured the perspective from the staff, and that would be the note that would go in. Our legal department was pretty wary of that when we started that. They were actually pretty nervous about it. But what they found was that we cut down on phone traffic to the legal department by better than 50% for the first 2 years that we started that program. And that, to me, was both in my own psychiatric practice, but also in the ethics service. Sharing notes, I found, was really a way to form better partnerships with patients. And at Beth Israel, we also are we think of ourselves as the transparency hospital. We started an apology and disclosure consortium many years ago that where we would acknowledge if we made mistakes, and we started a very open preventable harm initiative where we would put on our website, so you can go to Beth Israel Deaconess's website at any time, we put on our website any harms that have occurred to patients. And staff. It's both for patients and staff. And it's not just physical harm, it's also harm to patients' dignity or staff's dignity and respect as well. So we put that out there, and we had hoped that that would be a model that would be out there in that regard. So actually, we'll skip over this because Liz covered the Cures Act very well. The next slide. Okay, so the three questions we've had all along with all of this, and you can see this from Steve's data as well, is would OpenNotes help patients become more engaged in their care? Would OpenNotes be the straw that breaks the clinicians or the therapists back? And after a year, would patients and therapists want to continue? Bottom line is yes, 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 in all of that. That's really what we found. So we started our rollout in our psychiatry department. The faculty decided they would do 10 patients apiece and ramp up. So they chose the patient they thought would be the most beneficial and the least harmful. And then they've gotten more and more comfortable over time. In the social work department with our group, we gave staff a choice of either opting in fully and just opening up everybody, which is actually what most staff did. Just opened up their panels and fully from a point in time, not retroactive but prospective, from a certain date from the April 1st date, or they could do a ramp up study if they ramp up model if they preferred to. At this point, all outpatient and ambulatory therapists are open, within the departments. So we had some staff declined, and so there were a few that declined, but out of that, only 24 started and 28 out of 28 staff that were doing ambulatory. These are billed for a session, so these are only for billed for visits. So they are being billed as formal psychotherapy notes. And I think, again, a lot of we're doing this because a lot of Steve's, if you think of the population that Steve's talking about, it is generalizable. The VA system is, but this is our patient population is also very generalizable as well. So this includes our community health centers, as well as the outpatient psychiatry, in our therapists within primary care, within oncology, all the various services that were out there. Started with 440 patients at the start, and then we've now graduated. I think it's actually closer to about 5,000 patients who are currently participating in OpenNotes at the hospital. Common concerns. So as we've heard, everyone worries that it's going to cause harm, and one of the staff worry that it's going to have an increased, pressure of and work burden. They're going to feel a sense of pressure to get their notes done in a timely way. And I will say, as a manager, to me, I actually appreciated the pressure of them getting their notes done, because some of my more delinquent staff became much better at getting their notes done in a timely fashion. And part of it is they didn't want to feel embarrassed in explaining to a patient why was their note not in there. So. Next slide. Folks always worried about whether patients would misunderstand notes, so they were concerned about that. But next slide. On the other hand, I'm hopeful that the OpenNotes may actually enhance the therapy process and promote greater communication and understanding on both sides. So we think about it as really, it's an opportunity for grist for the mill, for the therapeutic mill, if you will, and really a way to connect with patients and to strengthen the therapeutic alliance. That's certainly been my view, and I think it's the view of most of my colleagues at the hospital. All of our staff were worried that they were going to have to re-language notes and processing the notes when they were particularly worried, will they be angry about certain content, right? And you heard that from Steve's presentation as well. So we're going to have to double chart, we're going to have to change our notes, we're going to have to start doing more process recordings, all those kinds of stuff, side notes, that kind of thing, and people were putting in much. But now what we found was basically the staff did not have to do that. They did not have to relanguage it. They did form a subcommittee to kind of think about putting together a thesaurus of words, and they actually found they didn't need to do that. They did have to explain to patients sometimes about, for instance, why do you put a mental status exam in every note? And why do you say a comment about my lethality, whether I'm suicidal or homicidal or whatever, in every note? So, there are certain things where we would certainly explain to patients about, what are the necessary professional requirements that we have, that we've got to document in there. And there was concern about, severe mental illness, especially psychosis and paranoia. But I will say staff learned, and they knew this from myself and that other colleague, our patients with severe mental illness, and particularly our psychotic patients, when we showed them the notes, and this is, again, the hard copy of the notes, that OpenNotes through their computer, but we started doing that, we found those patients tended to settle in more to the therapy. They stayed because they felt like, okay, you're not hiding something from me, which is a common concern. So we also developed an FAQs and scripts both for the patient population, for the staff population, and particularly, by the way, for your front desk staff. the receptionists, who oftentimes get bombarded with questions that patients in the waiting room will ask them that they don't ask the clinicians in the back rooms. So we found we had to do some work around that. All of those are on our the OpenNotes mental health OpenNotes website, and are there for anybody to kind of take if they're useful at all. So we had to anticipate all that, and with the thesaurus that we thought was there, we didn't really need to change that. So what did we find? Patients were pleased, right? They were not scared. They read their notes, they reported important benefits, and they shared their notes, and they wanted their notes. So the adverse effects that patients oftentimes worried about more, particularly in a system like ours, where it's a very interdisciplinary system, was that they were worried about what other providers would have access to the notes. So it's a little bit more about a privacy concern. They didn't want people who were more peripheral to their care to see the notes about that. But in our system, we can't segregate those notes. Our notes are part of a whole system in that way. But what was most important, and particularly I think for those patients that are just beginning therapy and you're beginning a therapeutic alliance, seeing a concordance between what the clinician says in the session and what's written in the note was really what strengthened the alliance and really, or confirmed the alliance. It was already a good existing therapeutic alliance. That's what patients wanted to see the most. And it's more when you hear about this on the medical as well as the mental health side, patients feel ambushed if they start to see stuff that there was like, wait a minute, that didn't happen. So, or that wasn't talked about. So in our study as well, one of the things we found in our study was that we found that our staff, patients never talked about reading their notes with each other. The clinicians were all waiting for patients to bring it up, and the patients were all waiting for the clinicians to bring it up. So we encourage you to think about bringing it up with patients, right? And most of us, I was trained in a very traditional analytic psychodynamic model, and that's what a lot of our staff are trained in. We wait for patients to bring things up, and so people don't bring it up. And this notion, I would say bring it up and ask about what the experience was like. So what we found was 18% of patients shared their notes with family, compared to 20 to 42% on the medical side. I would say that's that really is key, and that was there. And patients stopped reading their notes after a while because a lot of our notes, quite frankly, are a bit redundant. So they didn't need to kind of see them after time. There's a lot of redundancy. They read them less often. All systems have these nightmare patients that they worry about in their practices. And I would say basically those are always labor-intensive patients. Next slide. They're labor-intensive patients, and there's a contagiousness of staff anxiety. And I've heard this from systems across the country, all through the country, about that. The people worry about that. Those are labor-intensive patients. To me, the question is, does the OpenNotes, does it have the potential to limit some of the labor intensity? And my experience has been it really has been. All right, so I'm going to just give one example of here, and I'm going to skip the other ones that I have. I'll tell you a patient I had I had a long-term therapy group with probably the average length of time in the group was around 15 to 20 years. And all of my patients were opened up, and she would read her notes, and then she would get fully regressed and not be able to go out of the house for days until she came for her next therapy session. It was a very negative experience of her reading the notes. And when she read her notes, she viewed that everything I wrote was just a horrible, that I was documenting horrible things about her, that she was a horrible person. When the staff or the patients, the other patient in the group said, well, geez, can we see the note? She brought in some of the notes. We pulled up notes in the session, and the other patients in the group, they did this phenomenal work with her to say how distorted she was about the note, because it really talked about her resilience and how this is someone who struggles with everything and sees everything in the negative. And so when the other patients really could reinforce that, it was so remarkably helpful. And now, some years later, that same patient could read her notes without getting regressed. And it really was so helpful. I would say that's a hallmark. And I'll mention just one other patient. It took him 2.5 years to read his first note. And when he read his first note, he hadn't wanted it because he was afraid it would just confirm that he was a horrible person. Go to the next slide, Amanda. That it would confirm he was a horrible person. It took him 2.5 years, and when he finally read it, it confirmed that he was really, a very resilient person. And we talked about his strengths. But in that note, it was helpful for him to see it, but it just took him a long time. So we think about OpenNotes as one more tool in your bag of tricks, and that's really about it. So next slide. So the couple said, I'll just go through this. That was this patient here. His quote was, "I'd be petrified to look." And I'm not going to go back to the other ones that I had there. But these are examples of this. You know, OpenNotes it's one more tool for you to think about. And it isn't for everybody. That looking under the hood that's here, it's just upset. There are some patients, particularly our obsessive compulsive patients, who ruminate about stuff, who in fact actually sometimes it might not be so helpful for them to see the note. So you should think about who it's going to be helpful for and who it's not. Some of our obsessive compulsive patients have said, I don't want it, just like going to the mechanic. I'm not going to look under the hood. I'd rather not. And so that's fine. You know, it's really, again, it's not for everybody, but it can be for most in that regard. So bottom line is 80%, almost all the patients want to continue, and said it would affect their choice of future clinicians as well. Next slide. Right. And I would say, one other thing, and I'm going to just wrap up on this actually, is that we use this 70-30 rule that about, you know, when you think about patients hearing bad news, particularly a bad diagnosis, a terminal diagnosis, there are a lot of studies on the oncology realm that talk about how little patients can hear. And what I would say, the same thing is true in mental health. So if we're delivering this 70% of you're delivering bad news to a patient and they don't remember any more than 20 to 30% of what you tell them, and they remember 70% of it's good news, right, in that way, then we flip that. Why would that not be true with patients who are filtering things with anxiety, with depression, etc.? And so for us, for them being able to see the note really is in fact actually very informative and clarifying for them about things that they need to do. I've had a lot of my patients would actually post their notes in their homes to see and remind them of what they're supposed to be working on. And so it's again become a real nice tool to kind of complement the therapeutic work. Next slide. Next slide. Okay. And I would say, by the way, I would encourage you to think about including mental health patients in opening notes, just like medical patients. I think we are contributing unwittingly to stigmatizing patients with mental illness by saying they can't handle it, when in fact actually the data shows they can. So I'll stop there and thank you very much.
That was awesome. Thank you so much, Steve O'Neill. So we're switching into the Q&A part of the webinar. Joining us is Deb Walkenheim, who's going to be reading the questions from the Q&A section, as well as Dr. Kate DeRoche, who's the executive director of OpenNotes. She'll be joining us as well to answer some questions. I did want to let you guys know before we get to Q&A that we have a number of other webinars coming up in the next couple of weeks and months on pediatrics, oncology notes, inpatient notes. So if you're on a mailing list, you'll get updates about those.